it's my turn to present some recent research findings, hopefully of interest to the global, SPH community, not only HPAM. So I think most of you know me already, but for those of you who don't, my name is Thomas Rouyard. I'm a health economist by training and currently assistant professor at HPAM. And so today I'm gonna present some findings that got published quite recently, last month actually. And the topic is the effects of workplace interventions on physical activity and sedentary behavior. So basically, this work is about a comprehensive evidence synthesis on intervention effects. Let me start with just a little bit of background about physical activity and sedentary behavior, starting with definitions. It sounds, it might sound a bit obvious what physical activity is, but actually when you look into the technical definitions and categorizations in the literature, it's not that straightforward. So I thought it would be good to just give a few reminders on this. So what is physical activity exactly? Actually, it's the amount of energy we spend, right, when we move our muscles. And the unit researchers tend to use to measure the intensity at which we spend the energy is what we call MET. So it stands for metabolic equivalent of task. And 1 MET, let me just take the laser. 1 MET is actually the energy we spend when we're just sitting when we're resting in a sitting position. Then if you spend, twice as much energy as you spend when you're sitting, then you're going to spend 2 METs, and 3 times more, 3 METs, etc. And so then, depending on how many METs you spend, they're going to classify your level of physical activity into 3 main categories. Between 1.5 and 3 METs, you're in low intensity or light physical activity. Between 3 and 6, moderate intensity, and above 6, you're in vigorous physical activity. Just to illustrate that with some examples, so when you walk at a slow pace, on average, you spend like twice as much energy as when you were sitting. When you do some house cleaning, 3.5. When you play tennis, singles, not doubles, you spend 8 METs, so 8 times much energy. So that's for physical activity. Now, sedentary behavior, the definition is also based on these METs. So if you spend less than 1.5 METs, you're going to be in a sedentary state, but only if you're in a seated or reclined position. So there is also this position component of the definition. So it's good to have these notions in mind, because depending on how intensely you exercise, is going to have different effects on health outcomes, different health benefits. So let's look at the latest evidence on the effect of physical activity on health. There is actually a great paper that was published a few years ago now by the team of Eklund, showing that when you exercise at a moderate to vigorous physical activity intensity, actually, you lower your risk of all-cause mortality. So your risk of dying early, premature mortality. This is a meta-analysis involving a lot of individual data. I think it's more than 40,000 individuals included in this study. So it's quite robust. So here you have on the graph, you have the time spent on MVPA, so moderate to vigorous physical activity. And here you have the all-cause mortality hazard ratio. So compared to someone who doesn't exercise at all, exercising on average 15 to 20 minutes in moderate to vigorous intensity per day is gonna reduce this increased mortality risk by 50%. So it's quite a big effect. Yeah, so MVPA, substantial effect on all-cause mortality. I could also have shown figures on NCD development. We also see similar trends. Now, something interesting that they showed in the paper is that this negative relationship between mortality risk and physical activity also works at lower intensity level. So even if you just walk every day, it's going to have a beneficial impact on your mortality risk. Of course, you're going to have to spend more time walking, to reduce the risk, but there is a significant association. Looking at sedentary behavior now, we see the opposite pattern, right? So the more time you spend sedentary, here you have the number of hours spent in a sedentary state per day. The more time you're going to spend sedentary, and the more you're going to have an increased risk of all-cause mortality. So here the reference point is 7.5 hours per day. This is on average what people spend. And you can see that when you start reaching 9-10 hours of sedentary state per day, then the mortality risk increases quite steadily. Okay, so that's the first piece of robust evidence that was published quite recently. And then the second piece of evidence I want to show you is also from a study by the team of Eklund. And it's interesting because they showed that when you are physically active at high levels, 30 to 40 minutes of MVPA per day, then it can mitigate this increased mortality risk that you have when you're highly sedentary. So people who spend 10 plus hours per day in a sedentary state, if at the same time they exercise a lot, then this increased mortality risk is mitigated. So this is illustrated on this graph here. They categorize people into 3 categories: highly physically active, moderately physically active, and not physically active. And within each group, you have people who spend a lot of time in a sedentary state, moderate amount of time, and low amount of time. So those who are both physically active and who don't spend much time in a sedentary state, this is a reference category. You can see that even if they spend more time sitting, there is not a significant difference in terms of mortality risk, right? But as you become less physically active, then the impact of sedentary behavior, of sedentary time, starts to impact your mortality risk.
Thomas, I don't see anything being presented.
Oh, really?
Are you wanting to, the presentation is not up anymore.
The presentation is not up?
Oh, I
okay.
don't see it. Does everyone see it?
I can see it.
I see it.
Okay.
Yeah, I can see it as well.
Okay. Go ahead.
Okay, well, you
Sorry
scared me.
about that. Okay, sorry about that. You can go ahead.
Okay, well, yeah, sorry about that, Alicia. So the point here is that you can be physically active and at the same time sedentary. So spend high amount of times in a sedentary state, but also be highly physically active. So it's going to be important to consider these 2 measures, these 2 outcomes together when we're going to think about the impact of physical inactivity on health outcomes. Right, so what does the WHO say about guidelines and recommendations? So in 2020, they updated their guidelines mostly based on the new evidence I presented. So basically for physical activity, they say you should at least engage in 2.5 hours of MVPA per week. And this could be done, up to 300 minutes in moderate intensity physical activity, or up to 150 minutes in vigorous physical activity. Now for sedentary behavior, the evidence was not robust enough to have quantified, time-based recommendations. So basically, they just recommend to limit the time you spend being sedentary and replace it as much as possible with physical activity at any intensity. So in the literature, usually, when we say that people are not physically active or insufficiently physically active, we mean they do not meet these physical activity recommendation by WHO. In most of the studies, this is what they use, okay? Now a question is, how are people doing globally in terms of meeting these WHO guidelines, right? So there was a paper published last year by Strain and colleagues, which provided super interesting updated estimates on the prevalence of physical inactivity worldwide, actually. So here you have the prevalence of people who do not meet the guidelines by country, by region. So what can we see here? Well, first of all, the prevalence is quite high everywhere, right? You see in the States, between 30 and 40% of the population does not meet the WHO recommendation. In some regions like Middle East or South Korea, Japan, this goes up to 50% or more of the population not meeting the recommendation. So high levels of physical inactivity. When you look at the global estimate for 2022, it's about a third of the global population not meeting the recommendation. And what's quite concerning is that it has been increasing over the past 2 decades, right? The estimate was 23% in 2000 and 26% in 2010. So there is an increasing trend of like a pandemic of physical inactivity worldwide. On top of having updated the guidelines in 2020, WHO also launched a global action plan on physical activity, and they set a target objective for countries to try to address this trend. So the objective was to reduce this prevalence levels by 50% by 2030 compared to 2010 levels. And so in the paper I just talked about, they also provided a map of the countries that are on track meeting this target and those that are not on track. And as you can see on the map, the vast majority of countries are not on track to meet these WHO target by 2030. Okay, so most of the countries in the Americas, most of the countries in Asia are off track with high certainty level. In Western Europe, in some African countries, people are doing better, but overall, it's not so great, right? So, in this context, we need either more effective policies to address this trend, or a better enforcement of effective policies that are obviously not properly enforced. So that was for physical inactivity. What about global estimates of sedentary behavior now? So the thing is, we don't have global estimates of sedentary behavior because it's been more recently measured actually globally, and we don't have so much evidence from low-income countries mostly. But we have some evidence in high-income countries. There is this paper by Prince and colleagues published a few years ago where they looked at the average sedentary time accumulated by workers in high-income countries, right? So you can see that workers in these countries tend to accumulate a lot of sedentary time, more than 9 hours on average. And if you remember from the first slides I presented, at these levels, you have an increased risk of all-cause mortality. Not so surprisingly, a substantial part actually of this sedentary time is accumulated in the office. So office workers spend on average 7 hours per day in sedentary state. Right, so, only high-income countries, but preliminary evidence that people spend a lot of time in a sedentary state. So obviously, because evidence has accumulated over the past decade or so, there has been a lot of work done to try to reduce this burden of physical inactivity, right? Especially in the workplace. So a lot of work has been done to develop interventions that are going to increase physical activity or reduce sedentary behavior. You have many systematic reviews out there focusing on subset of intervention usually. So for example, mobile health strategies or sit-to-stand workstations or different subsets of interventions to reduce sedentary behavior. Now there is a problem with the existing literature is that when we want to compare intervention effects, compare across all different types of interventions, it's very difficult to do so in practice. It's very difficult to do so because, first of all, we have many different types of interventions. We have a high heterogeneity in terms of populations and outcomes studied. And we also have technological advancements that has transformed the field a little bit, how outcomes have been measured. So if you take like studies published before 2010, they mostly use self-reported measures, right? So they ask people, okay, give us an estimate of how much time you spend sedentary per day or how much time you spend exercising. And after 2010, people started to use wearable devices, trackers, etc. And so we have more objective measures of physical activity and sedentary behavior. So it's difficult to try to synthesize evidence using these two types of outcomes. So this is basically what motivated this work. We have been contacted by the Thai Health Promotion Foundation in Thailand because they wanted to implement new policies to reduce the physical inactivity burden. Thailand was one of the countries in red on the map I showed you earlier, and so they're worrying that it's going to worsen health outcomes and also economic outcomes in the long term. So we got a small grant from the Thai Health Foundation and also NUS in Singapore to conduct a broad, comprehensive evidence synthesis on intervention effects, right? So the objective of the work was really to provide policymakers and employers with robust comparative evidence on intervention effects by intervention type for the general working population. Another objective was to identify evidence gaps so that we can guide future research efforts, because it's been a bit difficult to know, what type of new interventions need to be developed given it's so the volume is so high out there. Okay, so let me talk about the search strategy and the methodology a little bit. I won't, go into too much detail because it's time is limited, but if you want to know more about the methods, I can refer you to the paper later. So briefly speaking, we decided to focus on the general working population, meaning adults aged between 18 and 64 without any specific condition that had been diagnosed and no mobility impairments. So in high-income countries, this is around 90% of the working population. We decided to include any type of workplace intervention as long as they were aimed at reducing physical inactivity. In terms of outcomes, we also included any types of behavioral changes as long as they were related to sedentary behavior or physical activity. And originally, when we started the project, the work was to conduct an umbrella review, which is a systematic review of systematic reviews, because the volume of papers out there was huge. So at first, we decided to include only systematic reviews with or without meta-analysis. So we conducted the search. We got a bit more than 6,000 records. And after the screening process, we ended up including 36 systematic reviews with or without meta-analysis. We proceeded with data extraction. And this is where the trouble started, actually, because we started to encounter many difficulties in deciding how to synthesize the evidence we were finding. So basically, three main problems here. There was a lot of inconsistencies in terms of how interventions were categorized across systematic reviews. So in some reviews, for example, digital reminders would be part of mobile health strategies. In another reviews, they would be part of nudges. Okay. So these inconsistencies made it difficult to, find some comparative evidence, or actually to communicate it in a meaningful way. Then second problem, there's not a lot of meta-analysis out there. So we were expecting, a lot of pooled effects, at least on some subsets of intervention categories, but not so many meta-analysis. And finally, a key point is that most of the systematic reviews we identified, after assessing the risk of bias, we found that most of them were of low or pretty low methodological quality. So we were a bit stuck in our evidence synthesis, process if we stayed at the review level. So we decided to go back to the primary studies, at least partly. So we deviated from our registered protocol to re-extract some data at the primary study level to be able to conduct some meta-analysis and obtain the pooled effects that were just missing in the literature. So, well, just briefly speaking, for the primary studies eligible for the meta-analysis, we only focused on the most reliable evidence. So we only included RCTs and studies reporting objectively measured outcomes. And we required at least 10 data points per outcome to be able to conduct subgroup analysis later. For all the other studies that couldn't be included in the meta-analysis, we performed the narrative synthesis. And we also used review level findings, but only for systematic reviews graded as, a low risk of bias, basically. So this is broadly speaking the evidence synthesis method we used. Again, for more details, I refer you to the paper later. Last point on methodology I want to point out here. Remember, there were a lot of inconsistencies in terms of how interventions were categorized in the literature, right? So we just proceeded with recategorizing everything in a systematic manner using the social ecological model. So we just classified interventions according to whether they had components targeting the individual level, interpersonal level, organizational level, or environmental level. So to give you a more concrete idea of what it looked like, we had 5 families of intervention targeting the individual level: self-monitoring devices, psychosocial strategies, exercise classes, digital reminders, and financial incentives. At the environmental level, we had 3 main categories: sit-to-stand workstation, where people can stand while working; active workstation, where they can engage into low-intensity physical activity while working; and visual prompts or posters, in the office. At the interpersonal level, we also coded interventions based on their social strategy. So that's interventions, leveraging peer effects or peer competition. And also interventions leveraging the management of companies or implementing policies within the companies to promote physical activity. So 4 levels and broad families of interventions targeting each level. This is how we coded the interventions. Right, so let's look at the body of evidence, what we found, and what the body of evidence looks like, basically. We identified 264 interventions, okay, published at the primary study level, of course. So almost half of these interventions targeted the individual level. So half of these interventions, used one of these 5 strategies here at the bottom. 24% use environmental level strategies. 20%, sorry, about a third actually multi-level strategies. So where the interventions just targeted, had some components targeting the individual level and some others the environmental level. And no intervention targeted only organizational level or interpersonal level. So individual, environmental, and multi-level interventions are, the overwhelming majority of interventions out there. In terms of population studies, you can see here on the slide, the vast majority of interventions were conducted in high-income countries, mostly in the Western world. 37% in North America, 36% in Western Europe, 17% Australia, New Zealand, only 8% in Asia, and only 2% in the rest of the world. So most of the evidence we have on physical activity and sedentary behavior basically comes from the Western world. In terms of population, well, not so surprisingly, 75% focused on office workers, okay, so desk-based jobs. 8% on medical professions, nurses, physicians. Only 6% on manual labor. And in terms of outcomes reported now, for physical activity, a third of studies actually measured step count, 25% MVPA, so moderate to vigorous physical activity, 6% looked at stair use. So to my knowledge, no RCT looked at stair use, that's mostly observational studies. And 35% any other type of physical activity outcome. For sedentary behavior, 2/3 of the studies measured sedentary time, whether it's sedentary time at work or total sedentary time during the day. 24% any types of sedentary behavior outcome, and 13% the number of breaks from sedentary time that people experience every day. Just a side note, remember, for studies to be eligible in the, for outcomes to be eligible in the meta-analysis, we required at least 10 data points. So only 4 types of outcomes met these criteria: step count, MVPA time, and sedentary time, whether occupational or total. So this is the results I'm going to present now. The meta-analysis results, the pooled effects of interventions for these 4 types of outcome, basically. So let's start with low intensity physical activity measured by step count. I'm only going to present the most effective interventions. Each time I'm going to summarize the effects on one given outcome. So for low intensity physical activity, we found that interventions targeting the individual level are those that produced the greatest effects. And on average, they managed to increase the number of steps per day by 900, around 900 steps. Multi-level interventions, we could have thought that when you target multiple levels, you would have a bigger effect, but actually, this is not what we found. Multi-level interventions also produce a significant increase in step count, but not to the extent that individual level interventions do. In terms of specific components, so we did a subgroup analysis, by component to try to identify the component that was the most effective. And we found that the combination of self-monitoring device and psychosocial strategy, especially gamification elements, with or without financial incentives, produce the greatest effects. On average, a bit more than 1,000 steps per day increase. And these effects are quite robust, when we do sensitivity analysis, when we exclude studies with higher risk of bias, etc. So this is quite a robust effect. Now, what did we find for MVPA, moderate to vigorous physical activity, which delivers the greatest health benefits, right? So here also, we also found that interventions targeting the individual level were the most effective ones. But as you can see, the evidence is pretty limited. We only had 5 interventions included in this meta-analysis. And actually, only one high-quality study found a significant effect. So it was a study testing self-monitoring and financial incentives that found that led to significant increase in MVPA, but not when self-monitoring alone was used. So basically, evidence is too limited here to be able to, to say that any component has a consistent, significant effect on MVPA. And finally, when we look at sedentary time, the type of intervention the most effective at reducing sedentary time, we find that this time it's environmental level interventions which proves to be the most effective. Especially sit-to-stand workstations. All these interventions here are actually sit-to-stand workstation intervention, managed to reduce on average sedentary time per day by 75 minutes. That said, most of these studies had a quite high risk of bias, including very small sample size. So the level of evidence is less good than the one we had for low intensity physical activity. So these are the main results from the meta-analysis, and I'm not showing here the results from the narrative synthesis, but they basically confirm these findings, right? So based on the existing evidence that is out there, what can we say with the highest level of confidence at the moment? As a reminder, this level of confidence is assessed using the results of the meta-analysis, the methodological quality of the studies, the narrative synthesis results, and the review level findings of high-quality systematic reviews, okay? Taking all this into account, we reach, at best, a moderate confidence in the evidence that we have at the moment. For step count, we know that we can increase the number of steps per day by 1,000, at best, okay? Does this translate into any sort of tangible health benefits at this level? Most likely. For adults younger than 60 years old, 1,000 step increments seems to be associated with a 15% reduction in all-cause mortality risk, according to a paper, nice paper published a couple of years ago. So not bad. We can also manage to reduce sedentary time by about 75 minutes per day at best. Does this translate into any tangible health benefits? Maybe. Maybe because, as mentioned in the introduction, the detrimental effects of sedentary behavior are going to depend on how physically active people are when they're not sedentary, right? But given that we have a high proportion of the population spending more than 9 hours of time sedentary, it's possible that we see a tangible health benefits by reducing this amount by 75 minutes, at least for some portions of the population. And for everything else, the level of evidence we have at the moment is too weak. Okay, we don't have enough confidence in the current evidence to draw any other conclusion about the other types of outcomes, including MVPA. So these were the main findings of this work, right? Now, just let me say a few words about the limitations. I have a couple of slides on discussion, and then we can talk about these results. So in terms of limitations, I mentioned that the original plan was not to conduct meta-analysis, right? It wasn't registered in our protocol, so there is a risk of selection bias with this post hoc meta-analysis that we try to mitigate using like strict objective inclusion criteria, but still there is a risk of selection bias. A lot of pooled effects that we have is imprecise because many studies out there use small sample size, especially when they tested environmental level interventions. There is some degree of subjectivity in the way we categorized, the interventions. Of course, we use the social ecological model, but for some interventions, it could be debated whether they belong to one category or the other. So if you change the category, well, you might find other results. At the moment, there is also a lack of systematic ways of synthesizing evidence from umbrella reviews. So we did sort of a dual approach, combining meta-analysis at the primary study level and review level findings, but the way we did that, it's not very systematic, so this could be criticized. We only look at post-intervention effects. Okay, so our findings do not say much about sustained effects over time on physical activity and sedentary behavior. Why didn't we look at effect over time? Is because there are just too many papers, too many studies, and it would have been too much work to also consider sustained effects in one single paper, but this work would be very welcome for further studies. And also, we couldn't really say much about the impact, by socio-demographic factors, how effects vary by income, by gender, by age, right? So this is because we didn't have access to disaggregated data most of the time. Most of the time, studies do not report effects across socio-demographic factors. So the takeaway message here, very high volume of research in this literature, but not so many robust effect estimates. Right now, we know how to increase step count by about 15% of the recommended daily dose. Okay, the recommended daily dose, it's 8,000, 10,000 steps per day. So not bad because we saw it leads to some tangible health benefits, right? We know how to reduce sedentary time quite substantially, but the health benefits are uncertain. We don't know how to increase MVPA. So on the research side, research efforts really have to be targeted now to how to increase MVPA, whether in the workplace or outside the workplace, because it delivers the greatest benefits, especially at a time where most countries are lagging behind, in terms of WHO target. Also, we really need properly powered studies because most of the studies out there, have very small sample size and tend to be underpowered. On the policy side, what we could say is that in line with what WHO is already saying, prioritizing interventions that replace sedentary time with physical activity rather than just reducing sedentary time. And maybe promoting gamification, so gamified interventions and financial incentives, because in the end, when combined with self-monitoring, these are the most effective ones. Very last slide on this presentation. We need to be careful when translating these findings into policy recommendation, though. First of all, because we don't have any evidence from low-income countries, okay? So we need to adapt that, adapt these interventions to, well, cultural factors, technology, work styles, etc. Many people work from home now, at least in the West. There is emerging evidence that associates remote work with increased sedentary time. So we already had an average of 9 hours per day, right? So it tends to be higher now. So we need evidence that these effective workplace strategies I just mentioned also work when people work from home. And finally, more work needs to be done, on people who actually do some sort of physical activity while they're working. So manual labor, basically, because we cannot recommend increasing physical activity when they're already suffering from detrimental effects of what we call necessity-driven physical activity, right? So we should also think of policies to improve the conditions in which necessity-driven physical activity is performed, on top of all the recommendations I mentioned before for office-based work, basically. Right, so if you're interested in these findings, just drop me an email and I'll send you the full paper. If you're interested in the methods, if you're interested in the subgroup analysis, for example. Thanks very much for listening. Okay, so I'm going to moderate the Q&A. So any thoughts, any questions on these findings?
Just a really thank you so much. Very quick question. While I still have a connection, I'm going to go into the tunnel soon. Did you look at any of the studies I reviewed? Did they include combinations of different strategies? So was there a more pronounced effect when companies, workplaces use both individual level as well as environmental level strategies?
The connection was not super clean, Terry, but I think you meant, did I look at the effects of intervention that target different levels, right? So multi-level interventions. Was that the question?
Yes, that's right.
Yes, we did. So we did, and many interventions actually combine individual level components and environmental level components, okay? But somehow the pooled effect estimates are lower on the few outcomes I presented. Lower compared to the only targeting individual level. Yeah.
Interesting.
Yeah, we did not
Is
that at all. Yeah.
Do you think that was because of the poor quality of the intervention or the implementation? That's a little bit counterintuitive.
It is counterintuitive, absolutely. So that might be a possibility, actually, because multi-level interventions tend to be tested by studies rated with higher quality, okay? On average, on average. And when we conduct sensitivity analysis, I said that the effect was robust with low intensity physical activity, for example, this plus 900 steps per day. But actually, when you exclude small sample studies, the effect is reduced by 25%. So it's like an increase of 650 steps per day, which gets close to what multi-level interventions actually produce. Multi-level intervention produce, if I remember correctly, 600 steps per day, and individual level 650 when you exclude these low quality studies. So yes, but not as much as, you know, um, I actually presented. That's a good point.
Thank you.
Yes, Honor, please.
Yes, Thomas, thank you for sharing your work. It's very interesting. So I was wondering if you had any studies after the anti-obesity medications are in the market. You know, I was wondering if these medications like Ozempic, Mounjaro, Zepbound, uh, are they creating less likelihood of physical activities because people are finding an easy way to lose weight, and then they are less likely to have these beneficial effect of these physical activities. I mean, that could be another thing maybe to look in the future.
Thanks, Honor. No, absolutely. Absolutely. That's a great point. It didn't even cross my mind actually to check that. Especially because, you know, we only focused on the general working population, so healthy adults, right?
Right.
So people who are diagnosed with, let's say, diabetes or any sort of, you know, condition were excluded from these studies. But that would be interesting to do big time actually, even within the general population, because I guess people, I'm not expert, but I guess some people take Ozempic without being diagnosed with any specific condition, right?
Right. Okay. So you
And
didn't have BMIs or any of these things
no,
to
because
control for that. Okay.
no, because when we had studies including overweight or obese individuals, we did not include them because we wanted to have clean pooled effects for the general healthy population.
Yeah. Thank you.
Yes, Naveen.
Thank you, Thomas. This was really interesting. I look forward to reading the paper. I'm curious whether you encountered studies that looked in more detail at like worker or autonomy and other aspects of the work-employment relationship to see if um, different categories of workers who might be more autonomous and be able to engage in physical activity during the workday differed from those who are in positions that are less autonomous.
By less autonomous, do you mean people with mobility impairments, for example?
No, I meant with job titles that um, enable them to sort of determine the course of their day in the workplace,
Ah,
as opposed to those who are, dictated to work in a particular location, doing specific tasks. There's a lot of literature on autonomy in work, and I'm wondering if that relates to physical activity.
yep, I see what you mean now, and unfortunately, we don't have this. We don't have this data. We didn't have this data. We were not able. The best we could do is a broad categorization between manual labor and so what they call white collar, in the literature. But that's unfortunately that's it. Yeah, that's it. We couldn't differentiate further, unfortunately.
Thank you.
But yeah, I mean, just to me, the most surprising about these findings were, so we found 214 studies, right, testing interventions. And when you look at the bottom line of what we managed to produce after all this investment of these resources, all this time, all these research efforts, it's a bit disappointing. I think, you know, what we're able to do. So I think research should just stop trying to prove that they can increase step count now or reduce sedentary time. I think it's okay. We've done the work. Now we really have to focus on MVPA. So how to get to people move more actively. This is about time now. And also, of course, I haven't presented it because we didn't do it, but how long, you know, do these gamification intervention and financial incentives, how long can they last, producing these increased effects? Okay, I'm just going to check the chat.
Jamal, I think an immediate policy implication of this work is for all of us to get standing desks at DSPH.
And not use Zoom.
We should use the evidence to, you know, to lobby for that policy change.
Yeah,
Some people do at our school.
Yeah,
We should measure them. We should use our accelerometers and measure them.
Yeah.
And then also with the new campus, you should put in that request. It may already be in the plans. I'm not sure, but
I think it is
now the time to. Yeah, this is now the time to actually make that request.
Yeah.
Well, yeah, I mean, that would be nice, no, but I think we should convince the school to set up deposit contracts. This is what I think can have a real sustained impact, you know, where people commit to a bit of money every week, and if they don't meet the physical activity goals, the money goes to charity and they don't get it back. I believe in financial incentives. Well, maybe because I'm an economist, but yeah, this is what I believe in. Okay, so there is a question in the chat. Could you discuss what types of organizational strategies were effective, if any? Thanks. Yeah, that's a good question because, so first of all, no single study tested an organizational strategy on its own. It was always combined with some sort of other components. And an example of that would be company management encouraging workers, you know, for example, going to the office and making some sort of speech just to encourage more physical activity or these kind of things. So basically management being involved to promote physical activity in the workplace. Yes, Nassim, please.
So, Thomas, yeah, this was really great. Thank you. Really interesting. And I really liked how you very clearly described the methods and everything. It was really clear to understand. So based on some of the results that you discussed, it seems then like not really focusing on trying to decrease sedentary behavior, but really trying to push people to exercise more. So it seems like in a way, like, you know, standing desks and, you know, take this many steps and, you know, all of that feels like it's being too limited. And actually, like, we're sort of like, there was a gap. The gap, you know, has just basically just increased. That maybe we've been focusing too much on these small nudges or interventions. Is that a true conclusion to make?
This is mine as well. So I 100% agree with that. To me, we should stop, you know, funding research aiming at only reducing sedentary behavior because the health benefits are just not worth it, right? Maybe for some people who really sedentary, you know, and who don't exercise at all, okay, but it's just a minor share of the population anyway. Especially when you look at the benefits of just replacing, even with 10 minutes, even with short bouts, of moderate intensity physical activity, this is what should really be encouraged. How to get people to move just more intensely, even if it's just a little bit, even if it's just bouts of 5 to 10 minutes.
Yeah, I would really, if I want to do something, I would encourage our school to get us join a gym nearby, you know, and include that in our daily schedule or something. Yeah.
Yeah, but yeah, that's also my takeaway from these findings. So
Yeah, thank you.
okay, no other question on the chat, I think.
Did Thomas, did any of the studies look at stair use?
Sorry, at what, Terry? Sorry?
Stairs.
Yes.
Stair
So
use.
yes. So yeah, I didn't mention stair use because we did not include those studies in the meta-analysis because we just focused on RCTs for that part. So stair use is only observational studies, and it's difficult, right, to reliably measure stair use. And so yes, there is an impact on stair use. So some interventions, for example, like motivational signs, or banning elevators between 2 floors, these kind of things encourage stair use. However, it's very difficult to translate that into any sort of tangible health benefits. So on top of having the methodological issue of the studies testing that, it's difficult to translate that into something tangible health-wise. So we didn't really talk about that in the paper.
Yeah, let's have a great this is great. Let's have a follow-up. I don't know if you know, but we're being invited to serve as the research partner for New York City regarding the implementation of the Active Design Guidelines 2.0. And so I think we'll have an opportunity to look at physical activity across a lot of different settings and different types of building and urban design features. So there could be an opportunity for us to do something really cool